very, very, very easy to diagnose, provided we did think about it. Clearly, we are dealing with a disease where normal red cell is going to be touched on injury in the microcirculation, and we will have a mechanical injury to this normal red cell, making a hemolysis, intravascular hemolysis with fragmented red cells on the smear, which are very easy to diagnose for people in lab. Then we will have thrombocytopenia, that is a consumption thrombocytopenia, and people may present with these signs of severe thrombocytopenia both at the skin level but also at the bleeding level. And we will have the organ dysfunction related to the microvascular injury and the opposite disorders and ischemia. One thing that is clear since years, but was not that obvious for us, the ICU people, is that TMA can be TTP, like thrombotic thrombocytopenic purpura, or HUS, like hemolytic and uremic syndrome, and in both diseases we have multiple organ involvement. So we are not able anymore to say, if it's neurological, it's a TTP, if it's renal, it's an HUS. This is not true. Another thing that is important is when we are dealing, and you have a typical case of TMA, there are some keywords that need to be highlighted, and we need to understand first if we are with a typical mechanical hemolysis. So the Coombs test needs to be negative. The other thing is that before any treatment, we need to collect sampling for having Adams 13 activity. We will go back to what is Adams 13, but actually it's a protein acting as a sizer on the Wilbron factor, making the Wilbron factor rheologically acceptable. And we also need to have a careful evaluation of the complement system to know whether this is implicated in the TMA. Other tests that we do at the start are mostly made to evaluate the intensity and the importance of organ dysfunction. So when we have a microangiopathy with hemolysis, thrombocytopenia, and organ dysfunction, this is enough for you to say it's a TMA. Nothing else is needed. Of course, we need to have the sign that it's a mechanic, not immune, but Coombs test has to be negative. And then we are working to understand if we have differential diagnosis as well as etiologies making TTP or AHUS obvious in the patients. So the algorithm for the differential diagnosis, you can see here that you have organ dysfunction, CNS, heart, and the kidney, but also the GI tract. We have thrombocytopenia, and we have the signs that we have a mechanical injury to the red cells that is non-immune. So this is a TMA, and this is enough for the diagnosis. The following step must be to have the confirmation. The lab needs to provide you with the evidence that we have schistocytes in the blood smear, that haptoglobin is consumed by the hemolysis. This is not immune, so the Coombs test has to be negative, and fibrin needs to be normal. It's not a DIC, it's a TMA. And DIC is one of the major differential diagnoses for TMA, because you, as ICU specialist, you know what a DIC from trauma, from sepsis, from extended cancer, or from other bleeding situations. But we need to understand that TMA is much rare disease, but need to be differentiated from DIC. So one of the things that need to be clear is that we need to understand that there are common points, but we need to exclude DIC. And DIC for ICU specialists, I would say it's quite clear, because you all know how to recognize a DIC. First of all, there is the clinical condition leading to DIC, and even if we have common points, we know how to make the difference. There are scores that are validated, and even if there are these shared mechanisms, the ISTH score for DIC or other scores, if you want to use them, help you to make the diagnosis of DIC. The second differential diagnosis is HIT. And of course, one of the major differences when you receive a patient with TMA is that he or she has never been exposed to heparin, so HIT is outside the context. But TMA may occur in a patient in your ICU having received a heparin, making it a possible diagnosis. So one of the differential diagnoses of a very rare disease is another very rare disease that is called heparin-induced thrombocytopenia. And we are assisted by many tests in the lab, and the PF4 antibodies, because they are central in the pathophysiological of heat, they are very easy to get in your hemato and hemostasis lab, so you would be able to have a test that has a great negative predictive value. And also, you have the 40 scores that assist you to make the heat diagnosis appropriately and will help you to make the differential diagnosis. So you have a TMA, there is no DIC, there is no heat, so you have either a TTP or a HUS. In adult patients, STEC HUS are a possible disease. They are usually seen in preschool children with a bloody diarrhea, and this is the typical case. But this may be seen in adults, but it's even so rare that I will not discuss this today. I will discuss two rare diseases that we are increasingly facing because the diagnoses are now made. We have either the TTP, which is an acquired disease in adult patients and is related to a deficiency of a protein that is cutting the Witt-Brenner factor. And if the Witt-Brenner factor is not cut, it's too long, and it will aggregate the platelets and lead thrombosis in the microcirculation. Or another disease that, because it's in adults and not in children, because there is no bloody diarrhea, it's called atypical as compared to the typical HUS, and it's called AHUS, and it's a disease that is increasingly recognized in adult patients and is related to the complement system. And I will go back to this. So this is a cartoon showing very clearly that this protein in green, ADAMTS13, is here to cut the Witt-Brenner factor and to make it rheologically acceptable with no thrombosis and no injury of the microcirculation. If this protein is lacking, Witt-Brenner factor is not cut, it's unusually long, and it aggregates the platelet, going and making thrombosis in the microcirculation. One thing that is very important is that this thrombosis is not the typical thrombosis that we know in DVT or pulmonary embolism. It's a thrombosis made by one Witt-Brenner factor and platelets. These are, unfortunately, a situation in patients who died, and these are post-mortem biopsies showing that this thrombosis can be in almost every organ. And I'm very thankful to Mary Scully, our chair, who reported that this cardiac TTP in patients dying after a sudden death is actually made by platelets, showing clearly that the involvement, the heart involvement in these patients is not related to classic myocardial infarction, but to TTP itself. The neuro system is the other problem in these patients. You can have any clinical sign, so even if the patient look normal, you have to spend time discussing with them, understanding their memory, headaches, and every single, even transient abnormality. And even in imaging, you can have any sign. There is no typical sign of TTP in cerebral imaging. Don't forget that if these patients have a normal CT, they may have an abnormal MRI, because this is a typical case of Press syndrome in patients with a TTP. If we are getting now to the other clinical situations in patients with TMA, we have to report on AHUS. A, atypical, because there is no bloody diarrhea, and because there is no, we are dealing with adults. And in this disease, we are dealing with a chronic and uncontrolled complement activation, leading to platelet aggregation, and we will have platelet consumption and thrombocytopenia, mechanical hemolysis, it is a TMA, blood clot formation, vessel occlusion, inflammation, ischemia, and hypoxia. And these patients we present with multiple organ dysfunction as are presenting severe TMA patients. Again, if it's not a TTP because ADAMTS13 is normal, is detectable, and if you have an acute kidney injury in a patient with TMA, this is an AHUS in adults. We will see that later with the presentation from Eric Rondeau and Mary Scully. It doesn't change the day 1 management, but it changes completely the day 5 management as well as the renal outcome. Again, AHUS in adults is not a kidney disease. It is a multiple organ involvement from complement activation, platelet aggregation, and microvascular injury. This is my last slide, and I would like to very much emphasize these elements. I think that we are all able to make a TMA diagnosis very easily. We have everything within several hours.